Okay. Well, good afternoon, everyone. It's my pleasure to introduce as this afternoon's Grand Round speakers one of our affiliate faculty members and also part-time supervisor of residents, Dr. Richard Meyer. Dr. Meyer is a graduate of the Medical College of Virginia, and he completed his psychiatry residency at the New York Downstate Medical Center in Brooklyn. He spent much of his career in the Hartford, Connecticut area, both in the private practice of adult psychiatry, but also as a member of the attending staff at the Hartford Hospital and also at the Institute of Living. During part of that time, he also had an appointment as assistant professor of clinical psychiatry at the University of Connecticut Medical School. Since arriving to Tucson in 2005, he has engaged in a private practice and also served as a staff psychiatrist at Sierra Tucson. Since 1980, he has been involved in the training of others in intensive short-term dynamic psychotherapy by Dr. Habib Davanloo. And this afternoon, Dr. Meyer will be discussing the therapy in his talk entitled Intensive Short-Term Dynamic Psychotherapy. Dr. Meyer.
I'd like to thank you for inviting me here today to speak about intensive short-term dynamic psychotherapy. There are a number of types of psychotherapy that are labeled intensive short-term dynamic psychotherapy. I'm going to be focusing on the one that was developed by Dr. Davanloo. The best way to do this kind of a presentation is with videotapes of live interviews, but because of confidentiality issues, that's not possible to do in this setting. So I'm going to use some descriptions of a clinical vignette and then some dialogue from the therapy of that particular person. I'd like to start with a brief description of a recent session with a patient to provide some introduction to ISTDP. The patient noted that he was struggling with anger, and he had recently had a flash of anger in relation to his wife, which he described as a brief hot flush in his face accompanied by an increase in heart rate. He noticed that the anger quickly turned to anxiety, and he withdrew from the setting with his wife to go to bed to shut down the feelings. I began to question him about the split second that he experienced the flash of anger, and he became very vague and indecisive in his description. He also became intellectualized. These defenses were pointed out, and then the patient became helpless to respond to my question about how he experienced the anger. He noted that he became anxious in the session as I was questioning him, and the anxiety was experienced as tension in his muscles. The situation in the session, therefore, became parallel to the situation that he was describing with his wife. He was experiencing some feelings in the session, and they quickly switched to anxiety. The interaction then moved to the transference relationship, the relationship between the patient and myself. I asked him how he felt toward me as a result of my asking him questions about his anger. He stated that he felt like a school child and that he couldn't get the right answer for the teacher. Finally, he smiled and stated that he was becoming irritated with me. I asked him how he experienced the irritation toward me, and after hesitation and a couple of interactions having to do with his helplessness and avoidance, he noted that he was getting a rise in feeling and felt as if he could throw the desk across the room. This was obviously a displacement of his anger for me to the desk. When pressed about his experience toward me, he said that he was afraid of what my reaction might be. And then he had a spontaneous memory of a situation with a teacher from when he was age 6. The teacher caught him punching another student and then grabbed the patient and pushed by the face and pushed him to the floor. He stated that his anxiety rose as he talked about this. This was a very anxiety-provoking memory. When pressed for his feeling toward the teacher, he admitted that he felt that he would like to punch the teacher in the face, leading to bruising of the teacher's face. He stated that it, again, made him very anxious to think about this memory, since he doesn't like to see people getting hurt. This led to another spontaneous memory of his early childhood, from the time he was 3, of his older brother pulling a knife on his mother, and then his mother kicking the older brother backwards, and the brother beginning to scream. In the session, he experienced a wave of very painful feeling as he recalled this memory. The session came to an end, and we were able to summarize the session. Anger in both the session and outside the session led to anxiety, which led quickly to shutting down the impulse through a series of defenses, such as withdrawal, smiling, intellectualizing, indecisiveness, avoiding, because the anger triggered very painful memories. And the disturbing early memories led to a wave of massive, painful, and guilt-filled feelings. I told him that I could see that this was very painful for him, but that he had to make a decision about whether he wanted to continue to avoid these feelings, or whether he wanted to examine the feelings, since the feelings were causing a major problem in his relationship with his wife and in other areas of his life. The pattern in this session is a common pattern in sessions where ISTDP is being applied. By the end of this presentation, I'd like you to understand how this technique is different than other forms of psychotherapy. Even though a lot of the core concepts that underlie the therapy are similar to the concepts that apply to other forms of psychodynamic psychotherapy. Let me first start with a few definitions and a brief description of the therapeutic process that I will later expand on and give clinical examples. This is a picture of Dr. Davenlew, who pioneered this method. It was taken a couple of years ago. Now, I'd like to go over some important concepts and definitions for ISTDP. The first definition I'd like to talk about is character traits. These are defenses that are designed to mask or avoid the experience of unconscious painful emotions. These traits are present in the relationship with the therapist as they are in the relationship with all other people in the patient's life. The defenses are dysfunctional. They compel the patient to avoid intimate situations, which could trigger the suppressed painful feelings. ISTDP focuses on the rapid identification of these character traits as they present in the therapeutic setting. The goal of ISTDP is to eliminate these self-sabotaging and crippling character traits and replace them with healthy traits that allow for intimacy and the ability to live up to one's potential. This is accomplished by uncovering and draining the unconscious emotional forces that led to the development of these traits. Pressure to the resistance is a description of one of the technical maneuvers in ISTDP. In ISTDP, the therapist is very active in the session. The activity of the therapist is focused on vigorously interrupting the patient's ability to use these defenses as they operate in the session. When placing pressure on the patient's defensive system, the therapist must adhere to the following principle. which is 100% respect for the patient, but zero respect for the patient's destructive resistances. Crystallization of the resistance in the transference. This, again, is a crucial element of this type of therapy. Crystallization of the resistance in the transference occurs when the pressure against the defense leads to a rise in anxiety in the patient, which is accompanied by a rise in intense positive and negative feelings, which are resisted in the transference. The transference is the relationship between the therapist and the patient. When the resistance is crystallized in the transference, the focus of the therapy quickly moves from a description of the patient's life problems to a rise in feeling and a focus on the transference relationship. The process of crystallizing and putting pressure on the resistances as they occur in the transference is the most powerful element of this technique. Dr. Davenlew has described this as the royal road to the unlocking of the unconscious. Head-on collision. This is another element of technique in ISTDP. This is designed to enhance the unconscious therapeutic alliance, which is the part of the patient that wants to join with the therapist to create a partnership. And I'll go into that in more detail later. This facilitates the emergence of an array of feelings, which may include pain, guilt, rage, sexualized feelings, etc. These feelings are first experienced in the transference and then spontaneously transferred to other key figures in the patient's life. The transfer of complex transference feelings from the therapist to current and past life figures is accompanied by vivid memories and leads to a clear view of the patient's dynamic unconscious. This gives the patient and the therapist a comprehensive view of the patient's psychic structure. Neurobiological pathways. This refers to the complete and fully integrated psychological and physical experience of the emotions associated with early traumatization of attachments, of key attachments. The full neurobiological pathway of these feelings needs to be experienced by the patient for the therapy to be effective. To be effective in fully resolving the patient's problems. Mobilizing the neurobiological pathway of these complex feelings, first in the transference, and then transferred to key figures in the patient's life is necessary for the resolution of the patient's problems. Murderous rage. The most significant emotion that needs to be experienced neurobiologically is murderous rage, which may be sexualized and is often fused with guilt and grief. The murderous rage must be experienced in the transference relationship and associated with elaborate visual imagery. When the patient is experiencing this murderous rage in the transference, the patient enters an awake dreaming state. The patient is awake, but is so involved with their inner experience that it's as if they're dreaming while they're awake in the therapy. Dr. Davenlew coined that phrase, awake dreaming state. Eventually transferred from, the murderous rage is eventually transferred from the therapist to significant past figures and relationships. The process of ISTDP requires that there be a diffusion, a separation of the rage from its associated guilt and pain. This ultimately allows the possibility of forgiveness of the self and others and the development of inner peace. Now, which patients are not appropriate for this kind of therapy? Patients with psychotic disorders, ulcerative colitis, patients who are actively abusing substances, certain types of impulse control disorders, patients with eating disorders who are malnourished, patients with serious medical problems, sociopathic personality disorders. Who is appropriate for this kind of therapy? Patients are appropriate for this kind of therapy who have problems resulting from unconscious conflictual emotions that result in the formation of characterological disturbances. These patients have difficulty forming and maintaining constructive intimate relationships. They tend to have self-sabotaging behaviors. And they present with a variety of symptoms, including depression, anxiety, panic attacks, somatization, etc. Now I'd like to move to a description of some of the core concepts that underlie ISTDP and, again, other psychodynamic psychotherapies. The two simplest core psychoanalytic principles which apply in this situation are, one, the unconscious exists, and two, psychic determinism. That means the forces that are present in the unconscious have a profound effect on the patient's conscious life. This triangle is called the triangle of persons. Each corner represents clusters of people, people from the past, significant figures from the patient's past life, clusters of people in the patient's current life, husband, wife, children, etc., boss, etc., and the transference, which is the feelings that the patient has, again, toward the therapist. Conflictual feelings having to do with intimacy or having to do with self-sabotage exist in all three clusters, in the past, in the current patient's life, and in the transference. For ISTDP, the first place that this has to change is in the transference. This is a really central slide in ISTDP. It's called the triangle of conflict. As you can see, each corner of the triangle is labeled impulse feeling, anxiety, and defense. These are interconnecting and interlocking concepts. And these are all unconscious phenomena. Patients have a reservoir within them of painful and frightening impulses and feelings. As these feelings begin to rise into consciousness, they create anxiety. Anxiety leads to the generation of defenses. Defenses have the role of reducing anxiety and keeping painful feelings out of awareness. Now, I'd like to go over each corner of this triangle. First, I'll focus on the impulse and feeling. Now, this again is another very important slide. These concentric circles represent layers of feeling that are present in the unconscious. Now, the center of the slide is labeled bond and attachment. These are the early bonds and attachments in the patient's life with mother, father, siblings, grandparents. When these bonds are traumatized, they lead to a layer surrounding the bonds of painful feeling. What do I mean by traumatization of these early bonds and attachments? I mean verbal abuse, physical abuse, sexual abuse, abandonment, neglect, severe rivalries. These situations traumatize the early bonds and attachments, and the patient's ability to form a bond becomes impaired because it's now surrounded by layers of painful feeling. The first layer is pain, the pain of trauma. The second is a primitive murderous rage. Now, the rage is toward the figure who perpetrated the trauma. The figure that perpetrates the trauma is usually a person who also has some positive relationship with the patient. So, and also, depending on the degree of trauma, the degree of trauma is proportional to the amount of rage. So less severe trauma leads to less severe rage. More severe trauma leads to very primitive, torturous, murderous rage. The next layer of feeling is the sexual feelings. So the sexual feelings are often fused with the primitive murderous rage. So the primitive murderous rage has sexual components. In addition, the patient's sexual life may be contaminated by aggressive impulses. The next concentric circle is labeled guilt. Again, a critical issue. Guilt is very important to bring to consciousness and what Dr. Davenlou says, to drain. Guilt is the force within the unconscious that basically says to the patient, you deserve to suffer, you deserve to carry your problems with you, you deserve to perpetuate your suffering to the end of your life. That has to be undone in the therapy. The next layer is the layer of grief, which has to do with the loss of childhood, the loss of significant attachments. Again, a very painful feeling. And then above that are the character resistances. As I was mentioning before, this is related to character traits. These character resistances keep the reservoir of these layers of feeling unconscious, outside of awareness. And then the final circle is the resistance against emotional closeness. When patients come into a therapy session, the first thing that the therapist has to confront is the patient's resistance against emotional closeness. The patient wants to put a wall between himself or herself and the therapist, to distance themselves. And this is easily understandable, because when the patient comes into the therapist's office, the patient is trying to form a bond with a therapist to do a very intimate and personal task. And this stirs up these layers of painful feeling, which are suppressing the patient's ability to form that constructive bond. Now, each of these layers of feeling has a neurobiological pathway. This neurobiological pathway needs to be fully experienced by the patient for there to be resolution of the patient's neurotic difficulties. Now, Dr. Davenlou, over many years and observations of many patients, has defined the neurobiological pathway of the key emotions. So rage. When a patient is feeling rage in the therapy session, they experience it as a hot feeling. Sometimes people call it a fireball that starts in their lower abdomen or groin and moves up through their body to their chest, shoulders, head, arms, hands. There's no anxiety when the patient is experiencing this rage. The rage is fused with other feelings, painful feelings, guilt feelings, feelings of grief. What's the neurobiological pathway of grief, of guilt? Dr. Davenlou observed that when a patient is experiencing guilt, they experience it as a painful constriction in their upper thorax and throat, accompanied by intense sobbing. On rare occasions, the experience is so intense that it can cause laryngospasm and actually be physically dangerous to the patient. So the therapist has to be aware of that possibility. Grief is the next layer of feeling, and this is experienced in the lower thorax and is accompanied by sobbing. The last feeling is called pain, and that's a more diffuse, painful feeling experienced throughout the body. It's very painful, and it's accompanied by sobbing. Back to the triangle of conflict. Now I'd like to focus on the corner of the triangle that's labeled anxiety. Now, again, Dr. Davenlou has observed over the years that anxiety can be discharged through three separate pathways. The first pathway is the striated muscles. When patients are experiencing anxiety in this pathway, they describe tension in their hands, forearms, shoulders, advancing to their neck, jaw, etc. This is in the skeletal muscle system, the striated muscles. Now, patients who experience their anxiety in this discharge pathway have a high adaptive capacity. Now, what does that mean? A high adaptive capacity is the ability to tolerate the impact of their unconscious. When patients experience this, striated muscle tension, it's a positive signal to go after the unconscious experience. The second pathway is the smooth muscle. Patients who experience anxiety this way basically report gastrointestinal phenomenon. So the patient will start to get anxious in the session, and they'll start to report nausea, the urge to vomit, abdominal cramps, the fear of having an episode of diarrhea. This pattern represents a mid-range in adaptive capacity, and it means that the technique has to be modified so that the patient can begin to be able to tolerate more intense levels of anxiety. The third system is the cognitive system, and this is reflective of the lowest adaptive capacity. And patients with this discharge through this system will describe the loss of ability to concentrate, hallucinations, the phenomenon of drifting, dissociation, and even more primitive defenses such as projection and paranoia. Back to the triangle of conflict, I'd like to move to the corner that's marked defense. Now, defense, when it occurs in the transference relationship, is termed resistance. Now, patients can be categorized on a scale of low resistance to high resistance. Patients on the left side of this scale have a low level of resistance. They're highly responsive to psychotherapeutic interventions. They have circumscribed problems, and they have a single psychotherapeutic focus. As you move up the scale to the right, the level of resistance becomes higher, until the far right, when you have a high level of resistance, severe character neurosis, diffuse symptoms and character disturbances, and a highly complicated core pathology. Now, the level of resistance is usually corresponds to the level of early traumatization. So if the level of early traumatization is high, that means that the level of pain is high, the level of murderous rage is high, guilt is high, etc. And this leads to a very high level of resistance. Patients on the left side of the spectrum have a high level of motivation. Patients on the right side of the spectrum have a low level of motivation initially, but their motivation can only be assessed after the resistances are removed. Now, the central forces of the resistance. Again, to repeat, when the defense against unconscious painful feeling is present in the session, in the transference, then it's called resistance. And the forces of resistance, they have two sources. One is the force of repression, and the other is the force of the superego, which is Freud's word, or the perpetrator of the unconscious, which is Davenlou's word. Davenlou decided to replace the concept of superego with the concept perpetrator of the unconscious because he thought that the superego was too narrowly defined. Superego is defined as the heir to the Oedipal complex. Dr. Davenlou's observation is that pain, guilt, rage, having to do with traumatization of bonds and attachments can occur at any phase of development from the earliest days of life. So the perpetrator of the unconscious is a sense of unconscious guilt that gives the patient the message that they need to punish themselves, that they need to perpetuate their suffering, that they need to continue to carry the pain within them to the ends of their lives. Now, classically, defenses were developed by psychoanalysts, and this is the list of classical defenses: repression, denial, sublimation, rationalization, reaction formation, etc. Dr. Davenlou developed another concept of defenses, which he labeled as tactical defenses. Now, there isn't a bright line separating classical defenses and tactical defenses, but tactical defenses are more clinically usable. They're more practical. They have clinical utility. So when patients are trying to communicate with a therapist, the tactical defenses that occur might include vagueness, helplessness, intellectualizing, emotional detachment and distance, diversification, which means that if you're touching on something that's highly sensitive, the person wants to change the subject, rumination, defiance, compliance, withdrawal, isolation of affect, and a state of limbo, meaning that the patient is unwilling to commit, that they keep everything up in the air. Now, the trial therapy. Patients are selected for ISTDP based on their response to a trial therapy. This is a 2 to 4 hour evaluation in which the technique of ISTDP is applied and the response of the patient is observed and carefully monitored. This can be divided into a 2-session experience. The goals of the trial therapy are to determine both axis 1 and 2 diagnoses, determine the suitability of the patient for this type of treatment, obtain a clear view of the unconscious emotional engine that drives the patient's difficulties, to determine the patient's level of motivation and ability to participate in this kind of an intensive process. And at the end of the trial therapy, the goal is to create a treatment plan. Now, there's a central dynamic sequence that occurs in ISTDP, and it's divided into phases. And these phases are really repetitive in the therapeutic process. The therapist and the patient cycle back and forth through them. So the first phase of the therapeutic experience is inquiry, asking the patient about their problems. As the patient tries to describe their problems, resistances start to come up. This leads to the phase of pressure on the resistances as they arise. The phase of pressure naturally leads to a crystallization of the resistances in the transference relationship with the patient, with the therapist. The next technical maneuver is called the head-on collision, which I'll explain later. Then there's the mobilization of the murderous rage, which is associated with guilt and pain and so on. And then there's the phase of working through. What's the phase of pressure? In the phase of pressure, there is an identification of the defenses, labeling the defenses. The therapist labels the defenses, putting pressure on the patient to relinquish the defenses, observing carefully and monitoring the discharge pattern of anxiety as it comes up in the phase of pressure, monitoring the rise in complex transference feeling, again, the transference component of the resistance. Let me give you an example of how a dialogue between a therapist and a patient might occur. This is based on real interactions with patients, but it's partially real, partially fabricated, and it's based on the initial case that I had presented. So the therapist would say, "Now, can we focus on how you experienced this brief flash of anger that you mentioned? Well, I didn't like what she had done. Now you focus on the reason you were angry. But the question is how you experienced this brief flash of anger. Well, I was angry. I was angry is a sentence. I wanted to leave the room. So now you'd like to avoid the feelings. I think that I was, now you want to intellectualize. Well, it was a very strong feeling. It was a strong feeling is vague. I don't know what you want from me." So now you take a helpless position. How do you feel about my asking you these questions? I feel like a schoolboy without the right answer. But that doesn't say how you feel. I'm afraid of your reaction. So you're experiencing anxiety. How do you experience that? My muscles are tense. I feel irritated. Irritated with who? Irritated with you. So you're irritated with me, and that makes you tense. If you let the irritation out, in terms of your thoughts and fantasies, what would happen? Now, the dialogue continues, and the patient describes having the urge to pick up and throw the desk. Now, this is obviously displacement from the therapist to the desk. The patient then has a spontaneous memory of an actual teacher when he was the age of 6 who caught him punching another boy and physically punished him. At that time, the patient had the urge to assault the teacher and feels a small part of this impulse in the session. This leads to the statement that he doesn't like to see people hurt, followed by memories of violence in his family and an upsurge of painful sadness. The next round of this phase of pressure, in the next round of this, the therapist will focus on the mobilization of the rage as it occurs in the transference. The patient described it as irritation, but that's just the tip of the iceberg. Now, before we move to the next intervention, which is the head-on collision, I want to bring your attention to the dual forces that are present in the transference. On the right side, you see the therapeutic alliance, and on the left side, you see the forces of resistance. These have both conscious and unconscious components. The conscious components relate to the actual person of the therapist. If there's a good feeling with the therapist, then the task is much easier. But there's an unconscious component of both of these forces. Now, if you remember back to the slide of the concentric circles of feeling, and then you think about the therapeutic alliance, the therapeutic alliance, the unconscious therapeutic alliance, is the center of that ring of circles. It's the original capacity of the patient to form a bond. That capacity, that desire, is the part of the patient that wants to reach out to the therapist and form a bond with the therapist around the task of resolving all the other painful feelings that the patient is carrying around. The resistance is related to the guilt in that series of circles. The guilt, the perpetrator of the unconscious, is that portion of the patient that feels that their suffering is right, that they should continue to suffer, and that they should perpetuate self-punishing behaviors to the end of their lives. Now, these forces vary in intensity over the course of a therapeutic session and over the therapy. This graph gives you an idea of how these forces vary. So at the beginning of a psychotherapy session, the resistance, which is the red line, is very high, and the unconscious therapeutic alliance is very low. And the complex transference feelings are also very low. As the therapist applies pressure, the resistance actually can increase as the patient becomes alarmed that some of these painful feelings are going to start to come to consciousness associated with painful memories. When the resistance becomes crystallized in the transference, and when the tension is high in the transference, the therapist then employs a head-on collision. If it's done correctly at the right time, this leads to a dramatic decrease in the resistance, a dramatic increase in the unconscious therapeutic alliance, and the emergence into consciousness of a complex set of transference feelings. Now, the phase of head-on collision. The main task of the head-on collision is to reach out, once again, to that part of the patient that wants to be free from his or her suffering. The goal is to join forces with the patient to defeat the resistances. The resistances that trap the patient in the belief that he or she should suffer and carry his problems to the end of his life. A successful head-on collision deactivates the patient's notion that the therapist is omnipotent and in control of the process. It points out the reality of the situation. which is that the only way that this can be successful is if the patient and the therapist form a powerful alliance and work together in a very intimate and personal task. Here's an example of a head-on collision, again related to the clinical vignette that I originally presented. So the therapist says, "You said you were irritated with me, but you're becoming emotionally detached. You're becoming more withdrawn. You're taking a defiant position, which is another way to deal with your anger and put a wall between the two of us. Let's see what you're going to do about this." "I don't know what to do about it. I feel very tense." Now, this is a helpless position. Now, look, you and I have a job to do. Our job is to identify and resolve the emotional forces that drive your difficulties. We have to create a partnership. I bring to this partnership my expertise in psychotherapy, and you bring your expertise in yourself, so that we can join forces. That's the only way we can do this job, unless you've decided you don't want to move forward. I do want to move forward. If you continue to take a position the position that you've been taking, emotional detachment, helplessness, avoidance, defiance, then it's impossible for us to move forward. It is as if you would like to put a wall between the two of us. This is, again, the emotional distance and the resistance to emotional closeness. It's as if you want to put a wall between the two of us, as if you don't want me to get to your intimate thoughts and intimate feelings. You want to prevent me from getting close to you. My impression is that you have enormous problems with intimacy and closeness. Do you think that that's true? Do you have problems with closeness, or is it only here with me? Yes, it's true. Usually at this phase of the head-on collision, when the therapist, again, is trying to join with the unconscious therapeutic alliance, there's a rise in feeling, a rise in sadness. Now the therapist addresses the perpetrator of the unconscious. I also see you have a problem with self-sabotage, because even though you came here of your own free will, you communicate with me in a way that makes it impossible for us to move forward. You defeat the process, and you make me useless to you. Are you a self-sabotaging person, the kind of person that ends up a victim? You know better than I do. Are you a self-defeating person? Now, don't just agree with me. Yes, I really do agree with you. Now, clearly, if you continue to interact with, in this way, the process between us will end in failure. And our final goodbye to each other will be a sad goodbye. The process will be a waste of our time. But I can afford to fail because I can't always be successful. But can you afford to fail? If we fail, I will think about our session and speculate about what I might have done differently. But you will carry your suffering with you. Why do you want to do that? What have you done that makes you feel that you deserve to suffer to the end of your life? What have you done? Now, if the head-on collision has been well-timed and the resistance is sufficiently crystallized in the transference, then the intervention should lead to the emergence of painful sadness, movement toward a view of the dynamic unconscious, and this is accompanied by the emergence of relevant memories and an array of emotions. This sets the stage for the next phase of the process. Now, the next phase of the process is really central and crucial, and it involves the mobilization of the neurobiological pathway of murderous rage. The first round of pressure and head-on collision usually lead to the emergence of painful feelings, which are experienced in the transference. The second round of pressure and head-on collision is aimed at helping the patient experience the full neurobiological pathway of the feelings of his feelings to the therapist, and leads to the emergence generally of some level of anger and rage. It is crucial for the patient to fully experience all the feelings that they have as they were described above. For the therapy to be most effective, the patient must visualize the rage. In this phase, the patient becomes fully involved in the process. Anxiety disappears, and the patient is totally engaged in the experience of the rage fantasy and its neurobiological pathway. The patient enters into, again, the waking dreaming state. Here's an example. Okay. The therapist says, "How do you feel toward me? Let's see how you feel toward me. I want to grab you and push you. And then what? Then I will start to punch you, and I picture a knife, and I stab you in the throat. And then what? I stab you over and over again. Am I still in the chair? No, you're on the ground. And then I go after your face. Am I still alive at this point? No. And then what happens? I continue stabbing and stabbing until you're very still. I see blood all over the place. I'm still? Yes. And if you look at my face, what do you see? Am I looking at you? I can't see your eyes. Look at them. What color are they? I can't see them. Look carefully. They are green." The patient becomes very sad, and there is the emergence of intensely painful and guilt-filled feelings. I see my father's face. Now, as the patient looks at the murdered body of his father, there is the intense passage of painful waves of guilt and pain. This usually takes 10 minutes, 12 minutes. This is followed by an intense positive and loving feelings toward the father, forgiveness of the self and the father, and eventually reawakens the capacity of the patient for intimate and healthy attachments. This is a summary of an extensive working through process that may occur in one session, but usually over multiple sessions. This dynamic sequence of pressure to the defenses, head-on collision, mobilization of intense and complex feelings happens repetitively over the course of the therapy. In summary, Dr. Davanlou's ISTDP is a unique and very powerful technique designed to rapidly unlock the unconscious. The technique can be applied in weekly 1-hour sessions or in blocks of therapy, which can be 4 hours at a time or 6 hours per day for 2 or 3 days in a block. The technique is very complex and requires intensive training and supervision. Through ISTDP, full mobilization of the neurobiological pathway of unconscious feelings occurs. This leads to enormous relief and lasting resolution of dysfunctional character traits, character pathology and symptoms. Dr. Davanlou's technique is clearly defined. All ISTDP sessions are meant to be videotaped, which is essential for supervision, teaching, and ongoing research. The review of videotapes of actual live ISTDP sessions is the most powerful teaching technique. Okay, are there any questions? Dr. Matsashik?
How do you approach a patient who either refuses to participate in the head-on collision, or are you ever at a point where you're concerned yourself about the murderous rage and your safety? How do you back off?
I mean, you have to make a judgment about the patient that you're dealing with. The murderous rage that we're talking about is not something that's acted out. It's something that's experienced neurobiologically and in terms of fantasy. If the patient starts to act out in actual behavior, that's called a defense, actually. It's called explosive discharge. So patients who are at home might say, you know, I was angry at my wife and then I slammed the door. But that doesn't say how you experienced your rage. That's an explosive discharge. If the patient has that pattern has to start to change, and the patient has to understand that that's not what we're talking about. In terms of resistance to the head-on collision, this is a voluntary process, and the therapist can only do what the therapist can do to reach out to the patient and try to engage them in the process. If the patient is unable to do it, then there's nothing the therapist can do. Maybe another approach would be better. Any other questions?
Outside of the therapy session, if the patient is experiencing perseveration as a chronic kind of characteristic, is that a defense or would that be the resistance?
Well, again, defense when it occurs in the transference is termed resistance. So defense outside the transference is a defense, okay? I'm not, perseveration, I'm not sure what you're thinking about when you're thinking about perseveration.
It's a distinctive difference between that and, say, procrastination.
Mm-hmm.
When you're perseverating, the way I understand it is that you actually know what needs to be done, and the procrastination is a conscious, active thing. So you say, I was supposed to mail that bill yesterday.
Yes.
And yet your behavior is somewhat compulsive in that you still don't mail that bill, even though you remembered, oh, I didn't mail that bill.
Yeah, so perseveration in that sense, there's a differential diagnosis. So then you have to determine, is this OCD, that a person perseverates and has trouble actually acting, or is it a self-destructive phenomenon, where the patient is setting up some kind of a disaster for themselves by not getting to some important issue. So you have to make a differential diagnosis. Yeah.
Do you have any suggestions for how one can pursue training and more learning around this methodology?
Yeah, I mean, if anybody is interested in this technique as a result of this discussion, I'm glad to talk with them about training. I don't know anybody else in this particular area who has expertise in Davinlou's ISTDP, but I'm certainly willing to talk with people if they want to have further training. Yeah. Dr. Davinlou has, done 5-year follow-ups. In the comprehensive textbook of psychiatry, he has a section on his therapy, and he talks about having people come for follow-up over a 5-year period. The people will report what they're experiencing, might even review the videotapes and in a consultative way to see what they were experiencing. But it's not clear to me exactly, what percentage of the patients have a high level of effect and what have a more moderate level of effect. I can tell you, doing this kind of therapy it's very impressive, the results. People change. People talk about being much more comfortable, much more emotionally available, much more able to connect. It really is very dramatic. There have been some studies about the effectiveness of ISTDP in various diagnostic categories over the last several years. So Alan Abbas, who's a psychiatrist in Canada, did a couple of studies on ISTDP with anxiety disorders. There was a study in the American Journal of Psychiatry within the last year about the same subject. But it's hard to evaluate those studies because it's hard to know exactly who the patients were and what their problems really were, what the origin of their problems were. And it's hard to know exactly what the technique was. That's why, videotaping is so important, viewing the videotapes, seeing who the patients are, and then seeing how the technique works.
Due to the intensity of it, isn't it better, or would you recommend that be done in an inpatient setting?
No, it doesn't cause adverse reactions. I've done most of what I do is once a week kind of psychotherapy, and the level of mobilization in that kind of a setting is moderate. It's not very high. Recently, I was doing block therapy with somebody from out of town, and we would meet 6 hours on a Friday, 6 hours on a Saturday. So at the end of the Friday's session, there might be a lot of disturbance from the phase of pressure and so on. And then Saturday, there would be, we would work through what happened. But no, there's not an, I mean, we're not dealing with, people with very fragile egos in this kind of therapy.
So taking any example of a pathology, you usually have more than one trauma existing, wouldn't you agree?
I'm sorry, you usually have more than one what?
One trauma.
More than one trauma, right.
With this method, does each individual trauma have to be brought through the process?
Absolutely. The whole complex, unconscious, all the areas of difficulty need to be brought up, worked through, experienced. Yeah, that's why patients with severe trauma, multiple trauma, the therapy takes a longer period of time.
The intensity and the acceleration of this process is sort of reminiscent of the flooding implosion techniques. Could you comment on that?
I'm not sure what you mean by implosion flooding techniques. There's no desire here to overwhelm a patient. If the patient, you're always monitoring in this system the patient's level of anxiety and their tolerance for the experience itself, and you try to keep the experience at a tolerable level. If the patient is flooded, then you don't want that to happen. You want people to experience their feelings and to get relief from their guilt, their pain, and so on. And at the end of the session, you want people to feel relief, not flooded, not overwhelmed.
Have you ever reviewed the videotapes with the patient?
No, I haven't done that myself. Dr. Davenlew has, and actually he's shown tapes of patients seeing their own tapes and making comments. But I'd love to do that. That would be a wonderful thing to do. Yeah. Any other questions? Well, thank you very much for coming. Really appreciate it.